Good evening, good afternoon, good morning, wherever you are. Welcome to this IDC Alumni Talk. We have a guest speaker session today. I welcome on behalf of all of you Dr. Aravind Srinivasan, who is the Managing Director of Aravind Eye Hospital, Chennai. I had shared the profile earlier, but still want to give a brief introduction. Dr. Aravind Srinivasan is a cataract surgeon and also a management professional, a very rare breed of where someone who manages both the operations, a person who is very passionate about cataract surgery, at the same time also has a huge responsibility of running this as a scalable operation. Um, those of you who have seen the video which I shared would be a excellent context for what he is going to talk today. And if someone of you who have not seen it, please, I urge that you, if you get a chance after this, please go through it because it's a very, very interesting thing to watch and get used to. I mean, get an understanding of what Aravind Eye Hospital is all about. And because a lot of his discussion today, whatever presentation that he has, will have a great bearing on the content of that video. Um, Actually, today we had a very brief chat with Dr. Aravind yesterday, and he had enormous amount of things to share. But what we said that we will focus is get us a good understanding of the Aravind Eye Hospital, its operations. But more importantly, I think is going to focus on talking about the Aravind Way, which is what he is very passionately driving as part of his current role, where he needs to look at how do they scale their operations. They have already scaled big enough, but if they need to go further, he has a huge challenge of scaling the operations without you losing out on the core idea of how eye care is delivered in the Aravind way. So he is not only looking at scaling this Aravind method, but also looking at how to take the eye care methodology of theirs to any healthcare beyond eye care, and that is the kind of the vision that he has while driving this. And so a lot of things have gone into this methodology. If you look at it in the early 70s, when they started, they were already sown the seeds of creating a very, very scalable operation, of which one third of it will happen with people who do not pay, which is an amazing operational wonder. Now, having said that, they not only have nurtured the process, but I felt that when he said that he will talk about the design thinking practice in Aravind Way, it clearly came to me and struck me that the practice that they are following is even before the word design thinking was invented. So a lot of what they are doing, they have done it on the by doing, by learning, and then improvising. And so what I think design thinking has done is probably given a nice wrapper to how they are able to communicate to the world outside. So it's very interesting to listen to a person, a cataract surgeon, and a person who runs the operations, what perspective he has and how he has looked at design and how he has implemented and also looking at scaling of their practice. So without much ado, I would request Mr. Dr. Aravind Srinivasan to take over the session. The plan is Dr. Aravind will probably look at a 35-minute to 40-minute session of your delivery of your ideas, and then post that we will take some time for questions from the audience. Over
Thank
to you,
you.
Dr. Aravind.
Thank you, Mr. Ravi. Appreciate the opportunity. Good evening, all. Maybe my presentation won't go for 35, 40 minutes. Maybe it's about 20, 25 minutes, and then maybe the question answer session can fill the rest. Let me start my presentation and let me share with you. Give me a minute. I'll have to sort this out. Are you able to see my slides?
It is
Yes.
coming up. Yeah, yeah, it's coming up. Yes, yes.
Good.
We are doing
Uh,
good. Please go ahead.
Good. Thank you. So just to give you a context of blindness, worldwide it's estimated that 36 million people are blind. India has a higher preponderance of blindness, though our population is relatively younger. The blindness prevalence is a lot more higher, maybe due to us being in the equatorial region, malnutrition over generations. A lot of these things contribute to a higher incidence of blindness. The good news is 80% of the blindness, there is a cure. A 10-minute cataract surgery can restore sight to 5.5 million people. A pair of spectacles can make a big difference. That's why you would see these lens carts of the world, titans of the world, coming in like what you see in the developed countries. So that's a market which is going to grow consistently as the population gets older. So in a country like India, it's estimated that about 30% of the population would need eye care. That means at least one checkup every year. About 10 million people will need surgery in a year. So in that context, if you go to Germany or UK, that will be about 60% because of the aging population. So about 30% have been touched. We are doing about 8 million surgeries now, 7.2 to 8 million surgeries. Probably for every surgical patient, there are about 10 patients screened. So we're probably touching about 100 million outpatients. So we still have a long way to go to really saturate eye care in our communities. So this is the background. So the picture is of our founder, Dr. Venkadaswamy. He founded this organization in the year 1976 at the age of 58. So he became a kind of a social entrepreneur after his first leg of work with the government hospital in Madurai. So he was instrumental in doing a lot of outreach program in Madurai, and he wanted to continue that. He was also a follower of Sri Aurobindo. That's why the name Aravind. In Tamil, he is called as Aravind. The name comes from the Sri Aurobindo. And he said, I have to give care to all. Now, that made all the difference. His deep compassion and his aspiration to give quality created this cross-subsidizing model. And he also didn't want to depend on donations, a donor base to run this organization. So that's how the whole model where paying patients would pay and three free patients. That's how that model evolved. So on the design thinking, you are all very much familiar with this. But I think as was pointed out by Ravi, I think what Dr. V brought was that strong purpose. He empathized with people who have no sight. I think that made all the difference. Then whatever was the natural progression to give sight, and that's how he went about. And as was pointed out, fits into a model which has been evolved now. So, Dr. V, the building blocks of Arvind kind of can be in three buckets. One is a strong value system. The value system, which I mentioned, nobody should be turned away because they don't have money. The structure has to enable people to come in and get care even if they are absolutely free. So that was very spiritual, and that was and came from a deep empathy. But the delivery system was very pragmatic. Dr. V kept speaking about McDonald's. He kept speaking. Imagine 1976 India, $150 per capita, and you had 80% of the population very poor. Maybe 50% lived below poverty line. Even those times, he was able to look at McDonald's and said, "Is there a connect? Can we learn something from McDonald's? Wherever you go in the world, even then, they had stores available." He said they have standardized their facility, they have standardized what they do, they have they've built replicable capabilities. Can we learn from them? And he also was very enamored by supercuts. Supercuts is a law. I'm sure many of you would have seen it when you travel abroad. It's a chain of haircuts. So he said, can we learn from all these people and safety checklist? So he had a very interesting mind, one end very spiritual, but the other end willing to look at the world very differently and are able to connect dots which seemingly don't get connected. So it gave interesting, innovative ideas, and that's how Arvind came into existence. And a lot of these things happened over the last 4.5 decades. Dr. V passed away in the year 2006. So his work is being continued as we speak. So he started with 11 beds in a rented building. Today, Arvind caters to about 100 million population. Tamil Nadu is about 75 million. Parts of Kerala. We have a hospital in Tirupati, Pondicherry, and Kerala we cover with three of our hospitals, Tirunelveli, Theni, and Coimbatore. So we pretty much we cover about 100 million population. In that 100 million, Arvind provides close to 48% of all eye care needs. So in Tamil Nadu, we do close to 50% of all eye surgeries. Tamil Nadu does about 750,000 surgeries. Arvind does about 400,000 surgeries a year. So that's the kind of scale for that 100 million population, what Arvind does. So the model is like in every healthcare facility, primary, secondary, and tertiary. So as you can see, we have those small centers, and then we go up to the tertiary centers. A typical tertiary center, like in Chennai, we will have capacity to handle about 3,000 to 3,500 patients a day, and then do about 300 to 500 surgeries in a given day. So that's the kind of capacity we are talking about in a large hospital. So this is what I said. It's about 100 million population, and our whole aspiration is to create easy access. Our model is to keep it affordable and accessible. So our facilities are open from 7 a.m. to 6 p.m. No appointments. People can walk in. So we have created a model which can absorb that kind of demand. And over the years, we understand the demand pattern. The summers are busier than the rainy season. During the festival season, the patient load is low, and during holidays it's very high because grandchildren have vacation. Children can bring their parents for surgery. So a lot of these things, patterns that we have learned over the decades helps us to manage the patient flow. So our range can vary from, we probably handle about 20,000 patients a day now, and it can vary from anywhere from 8,000 to 25,000 or 26,000. So we need to be willing to be flexible to kind of ramp up our capacity, the supply side, when the demand increases. Last year was a COVID year, so we were able to achieve about close to 60% of what we did. So in a given year, we see about 5 million outpatients, perform about 600,000 surgery, 580,000 surgeries, and probably about a million spectacles cumulatively, and of which 38% are free or steeply subsidized. So the entire work of Arvind is designing for non-customers. In a country like India, which I told you earlier, we are serving 100 million population, whereas the need is for about 400 million. So the non-customer population is far more than the served customers. People always ask us, why are you building such a large facility in Chennai? Chennai is a hub of healthcare. Many people come from different parts of the country. There are good hospitals in Chennai. There is Shankar Nethralaya, there is Agarwal. There are quite a few good players who have a national presence. But our logic was Madurai Aravind Eye Hospital was doing more surgery than all hospitals put together in Chennai. So we said that can't be true for a 16 million population, Chennai, Kanjipuram, Vellore, and Tiruvallur. It can't be true because Madurai Hospital covers about a 10 million population. So we said no, that whatever was happening was only about 40 to 50% of what would happen. That's why we put up a facility here which can double the capacity of Chennai and those. So that's how this hospital came into existence. So how do we go after these non-customers? One is a strong community outreach program. I'm sure you've all heard about eye camps that we go into the community. We screen them. We give them spectacles when they need it. And we transport the people who need surgery back to the hospital. Actually, due to COVID, as you can see, it's a very steep drop. We do about 100,000 surgeries, 110,000 surgeries through these camps. It's a very significant activity, and about 1/7 of the state's surgery comes through these outreach programs. And we also realized in the late 90s that these eye camps were good to a certain segment of population for diseases that could wait. But that was not true with all diseases. You can see that shift happening in somewhere in the early 2000s. People were living longer, and all that started giving non-communicable diseases like diabetes, hypertension. People were, I'm sure many of our families would have people in their 80s comfortably living and maintaining their diabetes for 20 years, 25 years. So they may have diabetes-related complication, hypertension-related complications. So you needed another model to address that. Those are conditions that can't wait for the ICAMs to come. So we set up something called as vision centers. We have now close to 100 vision centers. We cover a population of about 7 million people. It's a rural center, about 750 to 800 square foot, manned by a vision technician and capable of handling close to 90% of all problems locally. I need a pair of glasses. I have something fallen in my eye. I have a little infection in the eye. I have to do a regular checkup for a glaucoma. Check and let me know whether there is a diabetic retinopathy. All of those things can be connected. And these centers are connected to the base hospital through a internet connectivity. So we are able to see the images. We are able to give expert advice. So on a daily basis, we would we do about 2,000 teleconsultations through these vision centers. So that has been an ongoing process. It's spread across all the hospitals. That's how it works. The other challenge in India, now it's a little better, but going back to 70s and 80s, the resources were significantly scarce. Today, India has about 23,000 ophthalmologists, but in the last few years, the population the ophthalmologist population has grown, but it's nowhere near saturation. US has about 28,000 ophthalmologists for 300 million people. So we are about 1.4 billion. We have 23,000 ophthalmologists. And with all issues in healthcare, most of these resources are in the urban setting. 50% of our population is still in the rural setting. So it creates its own imbalance. So one thing that we have done significantly, which now has percolated across the developing nations, is in a developed country they have one surgeon, one table, one scrub nurse, one instrument. They typically do 1 to 2 surgeries per hour. So if you can replace it with one surgeon, 2 tables, and 2 scrub nurse, you're able to increase the productivity significantly. We don't have a choice. With 23,000 ophthalmologists, we have to reach all the people. Then we have to be innovative, not follow what the Western model shows us to do. The other challenge was the availability of nurses. There is a lot of challenge even today. Because the nurses qualified BSc nursing, that's a 4-year program. They don't want to stick to one specialty. They want to work in multi-specialty hospitals. So we had an acute challenge. And this was not even there in the 70s. We had a very few programs that were giving nurses training. So our founding team recruited school finished young women at the age of 18. And now we select about 1,200 young women every year. So these young women, we call them mid-level ophthalmic personnel. They did most of the routine clinical tasks. Doctors can focus on diagnosis and surgery. They led us to higher quality and productivity and lower cost. And these lives of young women also vastly improved. And today we have a dual mission. One is eliminate needless blindness. Second is to 1,200 young women, when you kind of give them a great opportunity and give them a good platform, when they come into the society, they bring their own children, family, they become productive citizens. So that's something which we take very seriously as part of our overall agenda of our organization's purpose. So you can see how it works, right? There is a surgeon who's sitting in the center, swings the microscope from one place to the other, and the nurse standing behind gets the patient ready, prepared for the surgery. So that in between time is relatively very less, kind of negligible. So if our model has to work, an average surgeon has to do 1,500 surgeries. And you'll be wondering whether the surgeon is, kind of driven to do that number. But that's not true. If you kind of break it into 12 months, it's about 150 surgeries a month, which is, if you break into a week, it's about 30, 35 surgeries a week. So it's not a very significant amount for a cataract surgery. It takes about 10 minutes. But what is more challenging is to get the whole supply chain organized, logistics. So if you have to do the volume that we are doing on a busy week, we will have to feed at least 5,000 to 6,000 people every day. And we have to transport 2,000 people from their villages to the hospital and take them back. So if you really ask me what are the real challenges, it's not in delivering eye care, it's the logistics that is a big challenge for us. How do you shift these people who are disabled, who have diabetes, who have hypertension, manage their diabetes, manage their general condition, and then perform a surgery, feed them, and put them back into the community. So, and because the attenders don't come, because there is no family support, this is a community initiative. So, an older person would say, "Oh, my neighbor is going. Oh, that person has gone last time. He has had one eye surgery. He's going for the other eye. I will accompany him. He will be my guide." So that's how this model works in the community. Just to show you, this productivity is important. As I said, many of the places don't do this kind of productivity because they have not figured out the logistics and built scale. Healthcare is a highly fixed cost driven organization. In our case, it's about 85% of our costs are fixed. So the more volume we send through, we are able to utilize our resources far better. So we have to conquer the logistics piece of the puzzle if we have to build those buffers to be able to keep the organization productive consistently. So because of the volume, the cost of the cost of providing services is also relatively very less. I mean, UK, why UK? UK has 70 million, Tamil Nadu has 70 million. So we do close to, this slide was made about 7-8 years ago. So we do probably about 2/3 of what the entire UK does. And their costing is, we are probably about 100 times less expensive than them. There is wage difference. There are multiple differences. NHS is a very complex ecosystem. But again, their per capita income is about £50,000, and our per capita income is $2,000 to $2,500. So we better be much more affordable than what they are in UK. And this is in US. US, an average cataract surgery costs about $3,450. At Aravind, it costs $88. So we consistently want to keep this very low because we also set the price in the markets that we work, because we provide 50% of the care. So the average patient will still get an affordable care if Aravind-like organizations maintain a certain level of price points to be able to work. And the other question that comes is, with this kind of scale, what is happening with the outcome? For us, it's very important to give a good outcome. Eyesight is something, it's not like a cardiac surgery. By the time you realize there is a mistake, you're not there anymore to see or anymore to talk about. But in eye care, that's not the case. Next day, if it's a cataract surgery, people will know whether you have done a good job or not. So it is very important for us to work, and we also do a high volume. So bad reports will travel much faster. So we are paying and free. So either way, it will affect our brand. So we're very conscious about the outcomes. So we focus a lot, and in fact, we would want Arvind's outcomes to be the benchmark for be a global benchmark. So we strive to compare with other countries which have programs, which have data, and we also publish this data in peer-reviewed journals consistently, so that it is available in the mainstream journals, so that people can understand and appreciate. These kind of publications gives authenticity to what you do. So it's important for us. We are also a large academic center. We produce about 100 ophthalmologists every year and about 200 fellows every year, about 300 ophthalmologists in this country. So we have to have a meaningful and purposeful program which stands the test of scrutiny. And in the late 80s, I'm switching gears, we were able to give a certain type of cataract surgery without intraocular lens for the free patients, and with intraocular lens to the paying patient. So our founders and the founding team were not very comfortable. We said we have to give equity, we have to give the same care to both paying and free patients. So they decided to get into manufacturing of intraocular lens. Those times, the lenses were made abroad, mainly in US. You would have heard about the companies Allergan, Bausch & Lomb, Alcon. They were the companies who were making lenses, and the market was a minuscule globally. So Aurolab came into existence, and today Aurolab supplies about 30 million intraocular lens in its journey. It has 12% of the global market share on an annual basis. Exports products. It's not only lenses, sutures, pharmaceutical products, some equipments to about 160 countries. The other segment of the work is it's not about Aravind alone doing what it is doing, but we've learned a lot of good insights. We have learned. So we established something called as Lions Aravind Institute of Community Ophthalmology. So that's how LICO is that's the expansion. So we help build capacity. We have not discovered a newer surgery or newer technique, but we have democratized what was available. So that democratization is a process, like what design thinking is. There is a process, there is a principle behind it, and there is a methodology to implement. So that's what we share. We share our principles and the methodology that comes. And we believe that it adds about close to 1 million surgeries every year, apart from what we do, and 30 million people through oral lab. So in Dr. B's name, we also have a basic research facility, a clinical research. Research is lacking in India. I'm sure all of you would agree, especially medical research. Most of it is done in the Western world. And obviously, they would focus on the Western issues, diseases of that population. So this is the time for us to focus, is what we realize. COVID has brought in a lot of emphasis on infections. But before COVID, the developed countries had forgotten about infections. They were focusing on lifestyle diseases like diabetes, cancer, cardiac diseases. Those are strokes. But our problem was fungal ulcers, bacterial ulcers. We still had a significant magnitude of those problems. So those were the problems. Those are the problems that this Eye Research Institute works on. So finally, this is the last but one slide. These are some of the challenges we consistently think about. How do we make waiting time of patients more meaningful? In a hospital, I was just telling Ravi the other day, yesterday, that the malls want you to stay longer and the customers want to stay longer. Whereas in a hospital, hospital wants you to stay longer, but patients are very restless. They want to go very fast out. So what is the via media? We need some time. They are impatient. So what do we do? Integration of research and academics with the clinical service delivery. Because we are now using electronic medical records, so we can start teaching and sharing and learning on a real-time basis. Unlike classroom learning, which used to happen earlier, we can make all of that online. As they see patients, can they learn? Things like that. And we are about 7,200 employees as an organization. How do we provide employees with a nurturing ecosystem? This can be, at times, can be a overwhelming proposition. Not easy to deal with emotions. It's consistently handling people. So it will be important for us to take care of our people and nurture their energy. And how to optimize patient flow for efficient care. So these are some of the broad questions that we are grappling with as an organization. Finally, let me conclude with this slide. This is a quote from our founder. Intelligence and capabilities are not enough. There must be a joy of doing something beautiful. And that's what he showed us, and that's what the organization strives to do. Thank you.
That's wonderful. So precise and so quick and so, as promised, you just finished within 30 minutes like your cataract surgery. Thank you so much.
Thank you.
Maybe we'll open this forum for questions. Of course, I have a few, but rather I would open it for you all, whoever wants to go first. If somebody has posted a question on a chat, Nimesh, if you could see them.
Yeah, no question in chat, but I think people will just
please go ahead. Anyone?
Hello. Hi.
Yes, go ahead.
Can you guys hear me?
Yeah.
Sorry for the background noise. But my question was, how did you transition the surgeons from performing, one surgery at a time to performing two at a time? How did that affect their performance, and what measures were taken to ensure that the precision was still there?
not at a time, we finish a surgery and then move to the next surgery when the patient is prepared. So typically what happens in an operating room, there are two beds now. So earlier it used to be one bed. You finish the surgery and then you take a break because it takes the time to shift the patient out, bring the next patient in. And that was not a productive time that was happening. And so we had to publish this data, present it because we had to show that it doesn't affect the outcome of the patient. Their its infection rates are better, outcomes are better. So that's what we had to do. See, it's a natural proposition. I mean, I'm a surgeon, so it's like you're on a flow. Things are moving ahead. You're on a flow, so you don't want to interrupt that. So it is easier to move from one place to the other. So it was kind of natural for the surgeons to pick it up. That was not a challenge for us. The challenge was arranging the logistics for us, feeding that fire. It's not easy to keep feeding. There are fast surgeons who can easily do about 8 to 10 surgeries an hour. How do you consistently feed them? So those were the challenges. And what kind of technology we would adapt? Which equipment works better? Which microscope works better? What kind of instruments we need to give? What has resilience? I mean, it stands the test of time because every set has to go to an autoclave again and then come back. So those were all some of the learning curves that we had to go through. And it's an ongoing learning curve. We consistently keep learning because the technology keeps changing constantly.
Thank you so much for clarifying. I really like the presentation as well.
So can I go next, Ravi?
Please go ahead. Please go ahead.
Yeah. Yes, Dr. Arvind, every time I listen to you and listen to Arvind's story, it's fascinating. I think it's one of the perfect examples of how very, very customer-centric thinking can lead to like a end user-centric, people-centric thinking can go how far. And I really like the way you're tackling non-customers, because I think we spend our life chasing customers, and there's a whole world out there with non-customers. I think that's a fascinating thought. So I have met you a few times. I don't know if you recollect. Maybe I'll just switch on my video. But
yes.
It's always amazing. I mean, during Honeywell time or in Philips time, so after we met, yeah. So it's thanks for coming down and talking to us. It's really wonderful. Thank you.
Thank you.
Thanks, Amish. Anyone has a question for Dr. Aravind?
Dr. Arvind, are you a specialist only in cataracts or any type of eye care?
No, I'm a cataract surgeon.
No, but as Arvind Eye Care System is
across the board. Cataract surgery is about 60% of the surgeries. Retina, glaucoma, cornea, across the board. Orbit, oculoplasty, pediatric ophthalmology. So it's across the board.
In design thinking, we recommend that co-creation and then experimentation and try prototypes and then proving. So how that is being incorporated in your whole system, because especially when you have risks involved in that, right? How do you really take care of those trial and errors?
So we are very cautious. As you know, in a healthcare setting, we can't take a lot of risks, and especially in an operation theater setting. Eyes are very unforgiving. You can't do things and you can't go and rectify it. So you have to get it right the first time. So we don't tamper with things which are very critical, but we try to make incremental changes consistently. So we have a structure that works. And also we have about, say, 7 of those large hospitals, 15. So there are people who are thinking a little innovative differently. They make those small changes that works positively, and then we try to quickly take it institution-wide. I think that is something which we have tried to do, allow people to. So as if I am leading Chennai, so I have space to make those incremental changes so that it doesn't affect the entire ecosystem. But if it works well, then it goes to the entire ecosystem. So we have tried to create that communication channel. And then if something else happens in Pondicherry or other Aravind hospital in Coimbatore, we will learn from them. So we have mechanisms in place so that some of our senior doctors would visit their hospitals. Their senior staff will come and visit our hospital. So there is an ongoing, we call us like an external sabbatical. So we have an internal sabbatical. People will leave that hospital and come and be in another hospital for a month. It's not of a long time, but 1 month is enough. They can see some things which are very different.
Very wonderful arrangement actually. Trial and error, takes care in a highly risked environment. I think it's a beautiful system to learn. But I know there is actually a lot of like Toyota production system. People have failed. So similarly, Arvind Eye Hospital. I mean, I read that Dr. B was telling that you can't duplicate the soul. Is it true? I mean, you may copy the systems and everything procedures, but then the soul is totally you cannot just copy it.
Absolutely true.
Yeah.
Absolutely true. So a lot of times what we are trying to do now also is trying to put that into the existing structure. So for example, when we design a new hospital, all hospitals have a free outpatient, a wing, and all our operating theaters are in the same floor, the same ecosystem. So when a patient comes to the hospital, they enter through two different doors, paying and free. But when it comes to the operating theaters, it's the same ecosystem. So where it matters, everything is the same. So that we don't, and all our supplies are standardized, all our equipment we standardize, so that people can't have a lot of leeway in trying to differentiate what it is. And the other important aspect on the soul is also how we structure our human resource, our compensation mechanism. Healthcare, we all know, it has kind of gone into a direction of a pay per procedure and for a doctor. So that kind of accelerates what there is a perverse incentive system. So in our case, all our employees are paid on a fixed basis. There is no incentive. You might be a highest volume surgeon, but your salary is same as somebody who's you're the same age of experience in the organization. So not everybody likes to work in Aravind. The type A personalities, entrepreneurial doctors would want to go to private practice. They will still work in Aravind for 5 to 7 years because it's a good training ground. But then they move on, and we are fine with that. We want people who are kind of type B personalities who will run a long distance and who will focus on a specific area. So that's the kind of population. So all these insights we have learned over a period of time. And the other important aspect is our recruitment strategy. 95% of our employees do the first job. We have no lateral entry in our doctors. We have no lateral entry in our nurses. So this is the only thing they know. A young girl at 18 comes in, this is the only job she has done till she works with us. A young doctor who joins at the age of 24, 25 after their MBBS continues to work. He leaves after about 5 to 7 years. 10% of them would stay for their career. So that's how we have kept consistency in our system.
Yeah, I think totally, a different system that you follow. So which is what very difficult for others to copy, implement, I think. It's a very classic, proud case of our country, actually. Innovation example, I think, is covered almost by all leading institutions in the world. Very nice to hear from you. First-hand story. Thank you so much for coming into the group.
Thank you, Extara. Anybody has any questions?
Ravi, I have a question. Dr. Arvind, thank you for a wonderful talk. So you mentioned about the non-customers that Unmesh also referred to. So in design, we start with the users or customers, right? And then we figure out what their needs are, gather requirements, and then go about solving their problems. Right? So now you say that about 3/4 of the potential customers are non-customers, right? You got 400 million, and you're able to serve about 100 million. So serving these non-customers, has it in any way influenced the way that you operate? Is it that these non-customers will just tag along with customers and then kind of figure out through word of mouth about the services that you offer, and then eventually trickle down to your organization for service? Or you let that happen that way, or is there some kind of a conscious effort to reach out to them?
See, I think creating accessibility is a conscious effort. Like coming to Chennai and setting up a hospital, it creates that accessibility. And then after that, going and reaching out to the community and setting up vision centers, going into the community and doing outreach programs. That's a way of reaching out. Second, also setting up a free hospital. People are scared coming to a hospital. That's one of the big problems. Hospitals are not the places where they are welcoming in many ways. And the cost is also, unforgiving, even for a middle class people would struggle. Without health insurance today, medical insurance, people would go struggle at any level in the society. We have consistently kept our prices low. So, for example, in Chennai, Aravind, the charges that we have is very similar to what we would charge in a Tuticorin Aravind Eye Hospital or a Dindigul Aravind Eye Hospital. So, the idea is to create the internal ecosystem and make it similar. So, our consultation, even for the paying patient, is 100 rupees in Chennai, whereas a competing organization would charge 500 or 600 rupees for a patient's consultation. Surgery may be 30%, 35% more than what we would charge. So those are all conscious measures that we take to ensure that people are welcome. And the other point is also on the recruitment of our mid-level ophthalmic, the nursing population. We go to the rural area. So the patients who come from a rural area are able to relate to them. These nurses are able to relate to them. Oh, they are like my father. They are like my grandfather. Oh, this is the society. I know them. So I think those are all conscious steps that we take in taking care of them. And the last step I would say is keep the dignity of the individual. Don't ask them to come 5 times for a surgery. Try to finish everything in one go. One visit is very difficult for them. Don't make it difficult so that ask them to come again and again. We may give it free. The surgery, say we are giving a 5,000 rupees surgery free. For 2 people to come and go, it may take about 1,000 to 2,000 rupees. So twice that free is gone. They have to spend 5,000 rupees. So those are all things that we are conscious of, and we strive to be aware of it and try to mitigate.
I have a question.
Yeah.
Can I come in?
Yes, sir. Yes, sir. Please go ahead.
I have a question. How do your competitors who have the part of the sophisticated hospital, how do they describe you or your system?
So they describe us as a kind of a what do you call a factory kind of a setup here, and so that's how they would describe us in the early days. But today, the whole data is available; it's all published. So they would see us as competitors. They are a little concerned about us because we come at a different price point. We work with a very different strategy from the existing hospitals. So that's how they would. I would think that's how they would perceive us. See, one of the challenge I find, in Chennai, we've been here for 4.5 years now. People don't go beyond the surface. Here is a hospital which has grown significantly in 4 years. The curiosity to know what have they done different. You can't fool 1,500 patients every day. You can't fool 150 people who are getting surgery every day. So there has to be something good happening, right? But I don't see that curiosity in hospitals. Maybe we are straitjacketed. The healthcare is straitjacketed. We are not able to go beyond what is visible. That's where I spoke about Dr. V. He was able to look at the McDonald's and connect it to eye care. It's not only us. I mean, you take several other fields. Shoulders Hospital in Canada, does this for hernia. High volume hernia, people go from all over the world to get a hernia operation in Toronto, Canada, shoulders. There is a hospital urology hospital in Germany, single specialty, which handles, and there is an orthopedic hospital in Germany, Ganga Hospital in Coimbatore, Narayana Hridayalaya in Bangalore. So all these hospitals have taken something and have made it into a mass operation. And so very few people kind of look at it and get all the pieces of the puzzle. They only take 1 or 2 pieces.
Thank you.
Venkat, you had an additional comment to your question?
No, I just wanted to say when I meant non-customers, I'm talking about the people who do not know they need an eye care or a surgery.
Okay.
And they say, so, qualitatively, their life would be so much better if they went for a simple cataract surgery, but they may not even realize that they need that. So, is there ways of reaching out?
That's the added question I had, Dr. Aravind. How people, there's a lot of people may not know that there is something that they need attention, they need to be served, and how do you even get to them?
But Ravi, you'll be surprised. We work in UP through our partners. We set up hospitals in Munshi Ganj. We have a hospital in Lucknow. We work with a partner now in Sitapur. So people people are very smart. People know they can't see. I mean, that is not a rocket science, right? I can't see, I can't see. I mean, you don't need a lot of education to say that. What they are worried about is, will I be set right? Will I get into a deeper problem? Will I have respect when I go and take care of this problem? Will it lead to a lot of expense to me? Will they maintain my dignity? So those are all the fears. People want sight. I mean, nobody says that I don't want sight. Everybody wants to see well. Who wants to be dependent on someone else? So if you can create that path, initially the risk takers keep coming and getting the surgery, but eventually people followed. When we set up in Amethi, this was about 9-10 years ago, we were surprised at the pace, in fact 15 years, 2006, at the pace at which the community recognizes and walks into your hospital. Okay. That's what I meant by, you don't have to do anything different to reach them. Okay. You will have to create the path and be consistent with what you do. Your messaging should be consistent, your service should be consistent, and then people find a way to reach out to you. And today's world, WhatsApp, social media, I mean, it is not very difficult. I mean, you will be surprised. Chennai Aravind Eye Hospital has Google reviews, 10 times the Google reviews of Madurai Aravind Eye Hospital. Okay. So the population is also very different everywhere. The country is changing so fast. So today's awareness and information to a non-customer will go very fast. Bulk of our non-customers are not in Tamil Nadu-like places. Mm-hmm. They are in states which are not serving well. I'll give you one metric. Okay. India does about 5,000 surgeries per million population, average, the country. Tamil Nadu does about 10,000 surgeries per million. Gujarat does about 10,000 surgeries. Maharashtra does about 10,000 surgeries. Karnataka does about 9,000 surgeries. UP does about 2,000 surgeries. Bihar does about 2,500 surgeries. Northeast is a little low. So Madhya Pradesh is a little better, 3,000 surgeries. So the skewing also does not come from, it also comes from states, healthcare, which are, there is a disparity.
Just an additional question, if you don't mind, Ravi.
Yeah, please go ahead.
Yeah. So, I really like the way that, removing these barriers, for example, you mentioned that, there is no appointment required in the first place, right? Anybody can just walk in. And most likely on the same day, they will be served and maybe operated also. And then they go home completely fixed. Well, that's fantastic, right? If you look at some of the government services that we have, take, for example, vaccination. Right? The whole idea of taking an appointment, booking a slot, going there, and there is only like 200 people that can be served in that particular vaccination center. And so all of these are so anxiety inducing and, very difficult for people. We can handle it. We have a phone and we have internet connection and all those kinds of things. I think this is essentially the lesson I think we can take from, Arvind, that, access is about removing this anxiety, people with less access to information, these digital gadgets and all that. So from the vaccination tracking point of view, maybe the system that they created with the Arvind Setu and all that is good, issuing certificates and so on and so forth. But, it put enormous barriers in the beginning itself, for just getting to the vaccination center and getting it. A lot of people went there because of all this confusion related to it. So this idea of walk in and get served the same day, that's fantastic. Is there any story or, something that, kind of made this happen for your system?
See, that's what I said. I think this is because that's where the community was able to do. We had to we went for an eye camp, bring the patients, bus them the same day, and next day morning we had to do the surgery. So we had to figure out this logistics repeatedly, and people are coming from a little far off distance because of our scale of work. So it is better for us to finish everything in one visit. So a lot of what we do, our service scale, our resource availability, all of that is designed to be able to serve them within a day. But this is not new. Even in Tamil Nadu, I'm sure Tamil Nadu, some other states have done it well as well. Tamil Nadu had 40% of deliveries happening in government hospitals, maybe 50% about 10, 20 years ago. The shift was to private. In the last 20 years, the government has created upgraded primary health centers to give delivery. They have incentivized deliveries to happen here. Today in Tamil Nadu, they say 84 to 85% of deliveries happen in a government setting. So even within a government, because they have created access, they have created and they have incentivized, positive incentive, like a kid. They will give something for the baby. They may give whatever the baby needs, and some money maybe also they give. So the parents, many of our nursing staff would want to go to the government setup, and it's really good. So I think the government is also waking up. Look at our own country. All of us have watched the below poverty line insurance scheme that started 20 years ago. We never spoke about insurance schemes. The government never spoke about it. The private segment spoke about it. So government have also realized, every government in this country, even the Prime Minister's scheme which he has launched, all of that says that the government is also very cognizant of the fact that healthcare is a big point of, like in US elections, people talk about healthcare. Today that has become a reality in India as well. So I think this accessibility is a primary hallmark of any good healthcare intervention. People will avoid if you don't give them that accessibility and affordability, and people will suffer even if they have a problem, if that is not there.
So can I ask a extension of a question?
Just one point. To pick up from Dr. Arvind, what you mentioned yesterday, which I think relates to the point raised by Professor Venkatesh, is that you mentioned about how you have a mechanism by which you don't wait for people to ask questions, that you would provide all the answers so that they don't have a question. I think you mean to, if you can just highlight about that a bit, and then we'll move to the next question.
Like I was saying, we handle 20,000 patients every day across the system. So if in Chennai we handle about say 2,000 patients. So if we don't have simple things like, if a patient we advise surgery, have we given them all information before they even ask us? Because every question, if you have to spend a minute, we have lost that minute. So we are consistently conscious about how do we add value so that every question that they might have, we are answering. So we will have a good signage, good information, a brochure in their hand, a video to show them what's the surgery, how does it happen, visually show them what will happen to them when their parents go through a surgical. So a lot of these things are done so that patients go through an experience during their care journey, so that most of the answers are given by sharing experiences ahead of time, so that they anticipate it rather than question us why it would happen.
Thank you. Imesh, you want to go?
Yeah. So just extending that question on the government healthcare versus private healthcare versus, the kind of scale we need in our country. Is government taking any sort of help or advice from you in terms of how, rest of the system, primary healthcare or secondary healthcare could be, sort of changed or innovated to work as a system, in a different way? Is there anything happening on that front? Because there's a lot to learn from Arvind, I guess, for government also.
In eye care, we work very closely with the government. As a country, we should be very proud of what our country has done. So, like no other country in the world, including China, does what we do in India in terms of eye care. I'm not talking about Aravind alone. I'm talking about the entire eye care fraternity. Yes. What we are able to give. China, with its population, it does about 2 million cataract surgeries. China's model is very skewed to the top of the pyramid, not to the bottom of the pyramid. So India has a very, very strong presence in the bottom of the pyramid. The strong fact that supports is 50% of all eye consumables in the world are made in India by Indian companies. So that is because we have created a huge market, and Indian government played a very significant role. Indian government took about $130 million loan from World Bank in the year 1996-97. It was a Danida-assisted program. And that program changed the way Indian eye care behaved and came to its age. So that created the whole district level monitoring system, incentive or giving money for each cataract surgery, 1,000 rupees. At that point of time, 500, now it's 2,000. So what PMJ scheme or what the below poverty line, that was done way back in 98, 99 for eye care. That's why you see a very significant learning. We are part of the advisory group. In fact, we keep telling the government should move away from eye care. Because government role is less than 8% or 9% in eye care delivery. Where people can do what they are doing. If government can pay 2,000, somebody is able to do. Let the government focus on conditions like HIV, tuberculosis, where sustainability is not possible. Eye care, fortunately, sustainability is possible. I think it's a long journey. Government is it's very difficult to pinpoint who is government. So we should work with the as an advisory capacity, and we can do.
Yeah, thanks.
Maybe we have time for just one more.
So, Ravi, I'll ask a question.
Yeah, please. Go
I think, Dr. Arvind, you had thrown some challenges at the community here, the design community. Would you want to focus on that? Because there are many mentors and professors here, and they can take it back to the students and the universities that they are in.
Absolutely.
So, if you could, talk about that a bit.
Yeah, as I said, we would like to have, young people, if they are interested in coming for an internship or being part of our system, who are willing to study from a patient's perspective, what we can do. We will be very happy to receive them. Some of the challenges which I shared are in the presentation. I had shared it with Mr. Ravi and Mr. Nimish, so they can share the presentation with you. The questions are there. So we are open to receiving resources, who could come and work with us. It's a little longer time also. So that would be definitely helpful to us.
Yeah,
so I think
Venkat,
we should take this as the beginning of a dialogue. Yeah. I think just the beginning of a dialogue between the education institute, the design education institutes and your institute. Hopefully, something more will come out of it.
Looking forward to it.
Venkat, do you have something specific that you want for your students?
No, nothing really at the moment. I will discuss these ideas with the students, and we'll see if there are students who would like to take up internships with Arvind, or do some projects as an academic project here at IIT. We will explore, and we will get in touch with Dr. Arvind.
Thank you.
So this is Prakash here, and I have some of my students who have gone and started programs in medical design, and I'm going to talk to them and see whether some of their students and some of their faculty and people would like to come and visit Arvind and see, apply design thinking and extend the whatever mutual beneficial kind of a program. Let me just talk to them, and then I'll get back to you, Nimish and Ravi.
Yeah, sure.
Thank you.
So we are exactly on time. We are 10 now, and certainly I would love the session to go on for a little longer. I'm sure there are a lot of questions which will just come up, maybe in the forum later, which certainly, Dr. Aravind, if there is something that they need a dialogue, I will share it with you. But first of all, I can't thank you enough to have taken time with us for about an hour from your very busy schedule. I know that you are sitting in one of the most critical and crucial and most demanding of jobs, and to spare this time is something that we really value so much. And what an eye-opening session. It's not only just telling us about the ethical side, the philosophy behind this, and also throwing some very significant numbers, which probably will leave a huge impact in us, and certainly will inspire us into looking at in our own work, inspired by the way that Aravind handles its operations, its innovation, and take a lot of learning from that. And I'm very, very thankful on behalf of the IDC alumni. I thank you, and then wish you all the best for the kind of scale that you're looking at. I'm sure in a year from now or two from now, you'll have a session which will have a totally different numbers for you to display. Thank you so much.
Thank you all. Thank you all. Appreciate the opportunity. Bye. Have a good evening.
Thank you. Bye.
Thank you all.
Good evening.
Thank you.
Thanks, Professor Ravi, for allowing me to participate.
Oh, not an issue, not an issue. It's a pleasure.
Thank you.
Hope you enjoy it.
Yeah, very much, very much. Bye.
Bye. Thank you. Good night.
Nice.